Quickly look at stroke. This is the most covered and well-reviewed topic, so I try to keep it short for our discussion because it's overtaught sometimes. Although there's a lot of question that does come from this topic. 25-year-old man is being evaluated after having suffered a traumatic head injury in a motor vehicle accident. He is found to have bitemporal hemianopsia. What arteries could be involved in this case? So bitemporal hemianopsia is optic chiasm, right? And he is having a traumatic injury that has led to the bitemporal hemianopsia. And that means that something has damaged his blood supply to optic chiasm, and that would have to be likely anterior choroidal. So anterior cerebral, middle and posterior cerebral will give you a much bigger stroke. And posterior communicating artery lesion, if it was an aneurysm, could sometimes affect the chiasm, but not from a loss of blood supply. So it's likely anterior choroidal artery. Let's see. Oh, anterior cerebral. So the question is blood supply, but I think the question is, so anterior choroidal comes from internal carotid before anterior cerebral comes off. So I am not sure what was the question writer was testing here. Anterior cerebral will not give you bitemporal hemianopsia by itself, unless posterior chiasm involved somewhere. All right, so stroke, you know all of this. It's a focal deficit. I'm going to skip a lot of these things. We have the hemorrhagic stroke and ischemic stroke. Hemorrhagic will be 17% of the stroke, so 1 in 7 or so. And ischemic is 6 out of 7 strokes. And the hemorrhagic stroke, we have intracerebral hemorrhage, and then we have the subarachnoid hemorrhage. And in ischemic stroke, we have a lacunar stroke, and then we have a large vessel occlusion stroke. And then large vessel occlusion can be atherothrombotic occlusion, meaning there was a throma or thrombus that got occluded, or it could be embolic, meaning that a clot came from somewhere. And then in 30%, we don't know what was the etiology. It looked like these embolic stroke, not lacunar, but the source is not identified. The blood supply of the brain is divided into two circulation systems, the anterior and posterior circulation. They're both coming from the arch of aorta, but arch of aorta gives the carotid arteries, while the vertebral artery comes off from the common carotid, and then vertebral arteries forms the posterior circulation as it enters the brain, and the carotid arteries, internal carotid arteries, forms the anterior circulation as it enters the brain. The anterior circulation or carotid artery gives off 3 branches before it splits into anterior and middle cerebral artery. So this is the split here. This is the anterior cerebral artery, and this is the middle cerebral artery. And before this, it gives off ophthalmic artery, anterior choroidal artery, and then sometimes the PCOM, or posterior communicating artery, also comes off of the internal carotid artery before the split, but sometime it comes from the middle cerebral artery after the split. But we technically count it in the internal cerebral carotid artery branches. So first 3 are the internal carotid artery branches intracranially, and then there is the anterior and posterior, anterior and middle cerebral artery split of terminal split. The posterior circulation, the 2 vertebral arteries joins to form a single basilar artery. Often the vertebral arteries give off the posterior inferior cerebellar artery at least on one side, but at least on one side, sometimes both sides of posterior inferior cerebellar arteries come from basilar artery. Basilar artery then had many penetrating paramedian branches, and then it gives the anterior inferior cerebellar artery, and then immediately after it gives the superior cerebellar artery, and then immediately after it usually splits into 2 posterior cerebral arteries, which joins the posterior communicating artery. So posterior communicating artery may come from internal carotid, but does not join the basilar, it joins the posterior cerebral artery. And the PCA usually does not give any of the superior cerebellar or any other arteries. So if you have an occlusion of one of these blood vessels, then you get a big area of the brain damaged, and that involves both gray matter and white matter. So there is the ACA distribution, anterior cerebral artery. There's an MCA distribution, middle cerebral artery. It's the largest, and sometimes we subdivide it into 2, the superior division and inferior division. And you can usually often see them separating out on imaging very easily. So MC is coming out, and then it splits at the end as a Y into the superior division and inferior division. Then there is the PCA, or posterior cerebral artery. this is from the posterior circulation, and this is the cortex itself. The brainstem will have separate blood flow separately. So anterior circulation, often you don't get the anterior carotid artery complete occlusion, but you can. And if you get the complete occlusion, you get both ACA and MCA damage. Otherwise, you get either ACA or MCA, and sometimes only a segment of MCA damage. So this is a complete MCA damage. If you get a complete MCA damage, it will involve the optic radiations in the parietal lobe. It will involve the motor and sensory cortex. It will involve the premotor and presensory cortex, and sometimes it involves the associated cortex areas too. It gives a lot of signs. It involves the speech area. On dominant side, it involves the auditory, but unilateral auditory does not cause any problem with hearing, but does cause problem with distinguishing the hearing. If you have only superior division involved, then there is sensory sparing. So it's predominantly motor syndrome. So you have hemiparesis and premotor problem and eye movement problem and motor aphasia. And if you have the inferior division involved, this is a sensory one. You get the involvement of the optic radiation. You get involvement of the sensory or Wernicke's aphasia, sensory cortex, sensory hemianesthesia, and so on and so forth. So usually you get a quadrant anopsia, either superior with the inferior division or inferior with the superior division, not a full hemianopsia with any of the specific damages. The posterior cerebral artery classically gives you this occipital cortex stroke, but it extends all the way into hippocampus. And that's something we forget. The posterior part of thalamus and hippocampus also PCA distribution. It can give problems like cognitive impairment, confusion, made-up memory, dissociative fugue, amnesia, and things like that because of the thalamic and hippocampal involvement. And then the occipital cortex will give you cortical blindness. So you can sometimes perceive some things, but you don't know the details. And you can get other strange phenomena, cortical phenomena that we may touch on later on. So these are the cortical stroke syndromes, one of the big branches occluding. The next come the brainstem syndrome, which is the posterior occlusion. Beside PCA, all the other posterior strokes are brainstem strokes. And they are very easy to identify because there's specific nuclei of cranial nerve in specific area. So there is usually some cranial nerve involvement when one of the posterior circulation stroke happen. So you're going to have stroke either in the superior cerebellar, anterior inferior cerebellar, or posterior inferior cerebellar, and then the paramedian branches. And any of these branches will give you a very specific syndrome. So these are some of the syndromes that are listed here. Some of them do come in exam, unfortunately. So it will be important to recognize some of them. Common one will be Weber syndrome. That's a third cranial nerve with hemiparesis. It's a midbrain one. There are three other in midbrain that becomes a little more complicated. This Claude, which is only ataxia, no cranial nerve. This Benedict, which is red nucleus, no cranial nerve. And then there is Perinod, which is again ocular control, third nerve nucleus, but only vertical gaze and not anything else, and no hemiparesis with Perinod. This is kind of a central penetrating branch syndrome here. This is Benedict. One of them will be Perinod here. Sorry. The Pons famous one is Millard-Gubler syndrome. That's a sixth and seventh nerve involvement with or without hemiparesis. And that's was the one I was pointing out earlier with the Bell's palsy. And then the Foville syndrome is also seventh and sixth, but here the sixth nerve nucleus is involved. And in Millard-Gubler, the sixth nerve fibers are involved and seventh nucleus is involved. There's slight distinction between the two on examination, but I'm not sure you need to know this for the exam. And then the Pica syndrome, which is the lateral medullary or Wallenberg syndrome with posterior inferior cerebral artery, is a common one that they ask. Medial medullary don't often ask. We saw an earlier question about medial medulla. This is the medial medullary syndrome. That question I didn't think was correctly written. Medial medullary will give you medial meniscus, so all sensory loss, pain and temperature, and cranial nerve 12, tongue, and hemiparesis. While a lateral medullary or Wallenberg syndrome, which is usually what is asked in the exam. So three, if you want to remember, will be Weber, Millard-Gubler, and Wallenberg. So one is midbrain, third nucleus. One is Pons, sixth and seventh nucleus, sixth nerve and seventh nucleus, and last one is Wallenberg, which is in the medulla, Pica, so posterior inferior cerebellar artery, and it doesn't have any specific cranial nerve. It's more about sensory loss and ataxia and Horner syndrome. It's not always present, but Horner is another thing you would see. All right, so let's translate it clinically. 43-year-old male presents with known medical history of right side weakness. Is playing with his son 6 hours ago. Right hand went numb, could not hold the bat. Walking to sit down, he noticed right leg was dragging. He sat down with rest to improve, came to the ER, and in ER, his blood pressure was high, and as you were putting the IV line, he got weak again. So this is called stuttering onset. It's very classic for lacunar syndrome. The symptoms start and then they get better and then they start again. If the break is too long, then sometimes they're called warning or sentinel infarcts or warning signs that yesterday I had some symptoms, got better, went to sleep, woke up again, and now had stroke again. And that is classic for lacunar strokes. Lacunar strokes have the stuttering onset. 65-year-old male with history of blood pressure and diabetes found to have severe confused this morning, complained not feeling well, not initially arousable, later not following commands, not moving his left side very well. Now, it most likely is not a stroke in real world. Although left side is not moving very well, it may be from the confusion. Often patients in confusion don't move one side more than the other or less than the other. And, the presentation is just too broad. If stroke is usually focal. Now, if confusion is going to happen from stroke, it's often thalamic infarct and often bilateral thalamic infarct. And so Babinski reflex is risks are reflexed all over, and both Babinski are positive. So again, both Babinski being positive goes for encephalopathy, or rather than it going from a stroke. Stroke will be one Babinski positive. So this one is unlikely to be a stroke and more likely to be a delirium or encephalopathy for some specific reason. Could be post-ictal encephalopathy after a seizure. An 82-year-old male with hypertension, diabetes with poor control presents with acute onset of weakness of his leg with dragging, and symptoms started to improve an hour later. And chronic history of numbness and tingling in his feet that was diagnosed as neuropathy, absent ankle reflex on the left and normal ankle reflex on the right. So normal on the right compared to absent on the left means that this is likely exaggerated ankle reflex. So it's being called normal because of underlying neuropathy. It is normal, but it's likely brisk. And that means that he probably has a stroke in that leg, and it's likely an acute stroke. An acute stroke in the right leg would likely be acute. So this is his right leg. So left is middle cerebellar artery infarct, likely lacunar infarct. 29-year-old woman with long history of depression, unable to rise from bed on waking up. She failed to move her left arm and leg, but she quickly raised it to arm catch ball. So this is psychogenic weakness. She denies that she was paralyzed on the left. Oh, this cannot be psychogenic. So yeah, if she has a hemi-neglect and she's not moving the left side, but then she suddenly responds and have a reflective movement, that can sometimes happen with a parietal infarct. And she has a hemi-neglect, and hemi-neglect will be a parietal phenomena, and it's likely the non-dominant parietal, but she has weakness on the left side, so it will be right parietal. Left nasally will fold is flutter. She has left Babinski. Yeah. So this is right parietal infarct, which is causing this slightly acute stroke. And that's why, but this reflex movement is likely because she either has parietal weakness, which is not a true motor weakness, but more of a sensory weakness or a neglect-related weakness. Let's see what the answer is. Yeah. Hemi-inattention and anosognosia from a right parietal lesion. 75-year-old woman presents to the emergency department with acute onset of severe right arm and face weakness with an expressive aphasia. So this is a superior division of MCA, which is causing it. So it has to be frontal lobe, and has to be right arm and face or left frontal lobe involvement. 68-year-old man has sudden painless onset of paresis of the right upper and lower face, inability to abduct the right eye, and paresis of the left arm and leg. Where is the lesion? So there's a cross lesion, left arm and leg, and right eye and right face. So cross lesion is always in the brainstem and at the level of the cranial nerve. So this is the right eye abduction. So adduct, abduct, outer movement. So that's third, but third and seventh. So it's maybe sixth and seventh is involved. So it should be adduction. The lateral is abduction. Yeah. So sixth and seventh involved. So this is that Millard-Gubler syndrome. So it's likely the Millard-Gubler is pons, and it's usually the ipsilateral pons of the face. It's the right pons involved. This is a Millard-Gubler classic presentation. 38-year-old woman presents for transfer care after recently moving to the area. She had stroke 10 years ago, and she has limited flexion of left knee and dorsiflexion of left ankle when she's walking, and she has this circumduction, swinging the leg out when she's walking. Her left arm is held adducted, pronated, and flexed at the elbow. A prior stroke affecting which of the locations? So this is a large area of involved arm and leg involvement, which will be likely what we call a dense hemiplegia, meaning both arm and leg is involved. Dense hemiplegia is usually internal capsule, deep, where a lot of fibers merge together, or brainstem, but there is no cranial nerve involvement. Because cortical strokes the is usually arm is involved more than leg in MCA, and leg is involved more than arm in ACA strokes. And even coronary radiata lacunar infarct, they're not dense enough. They're too spread out. So it's a very dense infarct, likely right internal capsule infarct if this is less left side problem. Yeah. So it's a dense hemiplegia in the internal capsule lacunar infarct. 34-year-old presents with 3-week history of intermittent dizziness and tinnitus in his right ear, intermittent. Patient states he has no previous history. Had is when he was doing a high school swim team. He has joined a gym a month ago, and when he used a rowing machine, it's worse. And he has a nystagmus in the left horizontal gaze, positive Romberg, so he's worse when his eyes closed and he's falling to the right. And hearing was intact bilaterally. And which of the following is consistent with his diagnosis? So he has a vertigo from internal ear involvement, but he has a tinnitus in the ear. So something is going on that is causing it, and it's happening with a rowing, meaning the change in abdominal pressure. When you row, when you swim, you have a lot of abdominal pressure, which is causing change in his pressure. So it's some kind of a vasovagal kind of a phenomena. So I would say that Bruy, but not in left carotid. He has hepatic edema is unusual, ejection regularly unusual, systolic in the left 25 higher. So either change in the blood pressure with systolic or Bruy. But I think this is internal ear problem. So I would go with Bruy in the left carotid artery. Let's see. Oh, there's no answer. Oh, subclavian stale syndrome. So it is the change in blood pressure between the two arms. So which is the subclavian steel syndrome, which is that the one subclavian is stenotic. So when you try to move both arms like exercising, the blood flows more to one side, which doesn't have stenosis, and less blood flow goes to the other side, which has stenosis. But that means that less blood flow to subclavian means less blood flow to vertebral artery, which is taking origin from subclavian artery, not directly, in contrast to carotid. And that causes the brainstem hypoperfusion, and maybe that's what causing his dizziness and vertigo. Although his vertigo and dizziness look like a peripheral one, not central one. All right, 56-year-old presents with weakness in her left arm and leg for the last 2 hours. She denies any loss of sensation or difficulty with speech. So left arm and leg. She first noticed symptoms of dropping her coffee cup, insulin-dependent diabetes, hypertension, 3 hours in arm and leg. So partial weakness with both arm and leg. So this looks like a lacunar motor infarct. DTRs are 2+, no text is present, patient's right hand dominant. Where is most likely the lesion? So lesion is probably internal capsule on the right. It's a left arm and leg weakness. So right internal capsule probably. Yeah. Pure motor hemiparesis and lacunar infarct. So lacunar infarcts, the reason I jumped to lacunar right away was because he said arm and leg involvement was the same. So that's a dense hemiplegia, meaning that one lesion is affecting a lot of fibers, both for arm and leg. Another reason to consider this as a lacunar is because it's a pure motor stroke. There is nothing else besides motor weakness. So if a cortical stroke, you'll have something else besides you have higher cortical dysfunction. If it's a brainstem stroke, you'll have cranial nerve. If you don't have anything, so it's in between. In between is coronary radiata and internal capsule, but coronary radiata is too spread out. You cannot have one lacunar infarct coronary radiata to cause arm and leg weakness. It has to be internal capsule. Coronary radiata was not even an option, so that helps you here. All right, so that covers everything. Let me stop here.